All right. Hi there. It's section 10, and we're going to talk about cardiovascular disease and risk management. I'm also going to hit on section 11 and how I want you to think about this. These are diabetes complications, and we have large vessel complications and small vessel complications. So when we talk about section 10, this is all large vessel complications that can happen from diabetes or can contribute to diabetes. Section 11 is all small vessel issues, whether it be retinopathy or kidney disease or even nerve damage. So just to keep that in mind when we talk about diabetes complications. So I know a lot of this overlaps because you will have cardiology units, but diabetes has fourfold risk of having a heart attack or stroke, developing cardiovascular disease, high cholesterol, and much more. So it's going to overlap, which is why I feel it very important to talk about this. There is a risk calculator that is out, and it's the atherosclerotic cardiovascular disease risk estimator plus. The plus just came out not too long ago, so don't use the old one. If you know about that one, use the plus. There's an app that you can put on your phone, or you can just go ahead and Google it, and it'll come up, and you can put all your patients' information in. It's for those that do not have already established cardiovascular disease, meaning past heart attack or stroke, and they are between the ages of 20 and 79. So I'm going to show you that in a little bit. It's much more enhanced than it has been in the past. But these are just some little tidbits that are important. So blood pressure needs to be checked at every visit. And right now, patients elevated blood pressure greater than or equal to 140/90 should have it confirmed on multiple readings. So that just goes back to hypertension diagnosis. I know there's new guidelines out that say optimal is 120/80. We want it less than that. I get that right now. These are the 2019 guidelines from the ADA. And it's so important that these patients with hypertension, diabetes, should watch their blood pressures at home. And there are some cheaper models of blood pressure cuffs that they can purchase. I tell them to bring it to the office with them at their visit, and then we compare them to the ones that we're using just to make sure it's accurate. So we want to make sure that they are at goal, and we want to decrease the risk as much as possible. For those with diabetes and high blood pressure, those who are at lower risk disease, which means that their 10-year cardiovascular disease risk is less than 15%. We want to treat to a blood pressure target of less than 140/90. And again, when I show you that calculator, you'll see what their cardiovascular disease risk is. In pregnant patients with diabetes and pre-existing hypertension who are treated with therapy, the targets of 120/160/80 to 105 are suggested in the interest of optimizing long-term maternal health. So we probably want to err on the side of more at the 120/80 range with those patients. And this is just general. If you have a blood pressure greater than or equal 140/90, it should be treated. And obviously we do lifestyle therapy, diet controlled. And if your blood pressure is over 160/100 or equal to, then you are okay with starting 2 drugs or a single pill combination, because this will help reduce cardiac events in patients with diabetes. We have to be much more aggressive. And treatment should include drugs that demonstrate to reduce cardiovascular events, such as ACE inhibitors, the ARBs, thiazide diuretics, or calcium channel blockers, which include the amlodipine. Multiple drug therapy can be used, because remember, blood pressure medication works in different areas of your body. But remember, never combine an ACE inhibitor and ARB, because they're so closely related. And you don't want to put it with a direct renin inhibitor, because go back to the pathophysiology and how it is used and why it is used. An ACE inhibitor or an ARB at the maximum tolerated dose, it's recommended first line for hypertension with diabetes, or if they have macroalbuminuria greater than 300 or microalbuminuria. All right. This next slide is an algorithm to help you for those that love charts, which most of us nurses love charts. So if anything, I know there's a lot of slides to this entire series. If you can just print out charts and put that in a folder and just put sticky tabs and say blood pressure, lipids, insulin therapy, that would be probably my best recommendation for you, because I know these slides are a lot of information. But it's important to know all the information, but to hone it down for your own use in practice, these really help. So the algorithm is self-explanatory in telling you what to start. So remember, ACE inhibitors are closely related to ARBs. So we usually start an ACE. And one of the side effects is a cough. Another side effect, angioedema, although it's very rare. But you may see on your certification exam something about angioedema, which would this be most likely related to, and it would always be an ACE inhibitor, because those are notorious for having that rare side effect. Also, the dry cough. It's an unexplainable dry cough, and sometimes we just don't know if it's from the ACE inhibitor, but the first thing we do is go to their med list and say, are they on any medications that can cause a dry cough? Sometimes we have to take them off of it and see if it goes away. After a couple weeks or so, we can pretty much determine whether it was from the cough if they've been off it. You can also put them on a calcium channel blocker, which is really good for African Americans, and as well as thiazide diuretics. But it tells you here exactly if they have albuminuria or not. If they do, then ACE and ARB is best because it's for kidney perfusion. And if not, then you can have a little bit more choice. So it goes down from there. And I'm not going to go into any more detail about hypertension because I know you have that other unit that talks about that, which is this. With these, remember, every blood pressure pill is working in a different area. So if it's working in the kidney area, you always have to monitor labs. So we want to make sure that your kidneys are tolerating them. So, and especially even a diuretic, because where's the thiazide diuretic working within that loop of Henle? Remember that? Versus a loop diuretic, but they're all working in the same area. It's just higher up or lower down. So it's going to excrete more potassium or not, which is spironolactone is potassium sparing, and that's used more at the end of the loop of Henle area. Okay, so patients that are not meeting blood pressure goals on three different antihypertensive should be considered for mineralocorticoid receptor antagonist therapy. So those are just going to some of the other more rare drugs. Like you can try clonidine with those patients. Sometimes we go to hydralazine. So those are just some of the other classes. So there's many other classes. And as far as lipid management in adults not taking statins or anything else, you should always get a lipid panel when they're diagnosed. Now, this recommendation per expert consensus says to get it every 5 years if under the age of 40, or more frequently if indicated. I get them more frequently on my patients. I get them yearly. But again, if these people are under 40, you know, I still think 5 years is a long time, but this is expert consensus. Obtain a lipid profile at any initiation of statin. So if you need to start somebody on it, then you check it in 4 to 12 weeks after you start it. You're going to get the best bang for your buck within those 12 weeks. After that, if you do increase the dose, you're not going to get as big of a lowering effect as you are putting them on that initial dose. And for all patients with diabetes and cardiovascular disease, with a cardiovascular disease risk greater than 20%, high intensity statin therapy is recommended. And then for those less than 40 years with additional risk factors, then you talk about doing moderate intensity. 40 to 75 is a recommendation. Greater than 75 is a B. Without any disease, you can use a moderate intensity. But again, this is going back to that plus risk calculator. If you have any cardiovascular risk disease, they should be on a high intensity statin. Many times they've been to cardiology and they're already on a statin. They should be. If they don't tolerate the statin, then you put them on the maximum dose. And sometimes we need to add ezetimibe, which is Zetia. And now we have the new PCSK9 inhibitors, which is the injectables that really work well, lowering the LDL and as well as the particles. And remember, no statins in pregnancy, those are contraindicated. We must not forget insulin resistance, and with insulin resistance, a lot of times comes high triglyceride levels. And if we first get a very high triglyceride, we have to make sure that they don't have pancreatitis, because that is a complication of that. But we need to address lifestyle factors, so they most likely have a metabolic syndrome, obesity, chronic kidney disease. Not all people do, but again, we talked about the metabolic syndrome in the past and how important that is. If you're going to treat hypertriglyceridemia, a combination therapy has not been shown to improve outcomes and generally not recommended, as well as statin and niacin has not been shown to provide additional cardiovascular benefit alone. So what we usually do is put them on a fenofibrate and fish oil. Fish oil usually is only covered if they have triglycerides greater than 500 as a prescription. There's the Vascepa, which is the preferred one now. There's also Lavazza. There's some over the counter, and the only one I recommend is Viva Naturals, because it does include the amount of EPA and DHA to equal 2,000 milligrams, and you only need to take 2 a day. You tell them to put it in the refrigerator. It reduces the fish taste. And some of them, such as the Vascepa, has been known to reduce triglycerides by 45%, and they should stay on it. Fenofibrate's also a good option, as well as Gemfibrozil, but those are also metabolized in the liver, so you want to watch liver enzymes. So it's not uncommon to get a complete metabolic panel, because then you're seeing the kidneys and the liver. Antiplatelet agents, I'm not going to go too much into that, other than there are some added recommendations that probably came after this slide set came on how we really have to be careful with prescribing aspirin. It's not as recommended anymore as it used to be. But these people that have cardiovascular disease may be on Plavix because perhaps they had a statin, or if they had a stroke in the past, they're going to be on statin therapy. But these are just recommendations per the ADA guidelines. Routine screening for coronary artery disease is not recommended. Doesn't improve outcomes as long as they're treated, and that would probably be, that is talking about getting a cardiac catheterization. No reason to do a stress test unless they're having signs, symptoms, or reason to have a stress test. But if someone has unexplained dyspnea, chest discomfort, vascular disease, bruits, TIA, strokes, claudication, peripheral arterial disease, or their EKG is abnormal, then that's when you need to go a little bit further and get those. Anyone with atherosclerotic cardiovascular disease, ACE or ARBs, are recommended to reduce cardiovascular events. And those with prior MI, beta blockers should be continued for at least 2 years after the event. And patients with type 2 with stable heart failure, metformin can be used if the GFR is greater than 30, but don't give it to anybody with congestive heart failure and if they're unstable. And usually when you go into the hospital, they take you off the metformin anyways for diagnostic testing reasons too. All right. Also, with patients with type 2 diabetes who already have cardiovascular disease, SGLT2s, GLP-1s are good, which we talked about in the medication management. All right, now let's talk about microvascular complications in foot care. Chronic kidney disease, those are small vessels. At least once a year, you need to check their urine for albumin. It's a urinalysis. They check for microalbuminuria. Patients with type 1, you do it every 5 years. In all patients type 2, we do them every year. And how are you going to prevent this from happening? They have to get their blood glucose under control. You can't have all that sugar running through their kidneys and filtering through, because then that's going to cause issues with the small vessels that they have in their kidneys. It's going to cause kidney damage, and now you're going to start spilling microproteins. So glucose, that's why the SGLT2s and GLP-1s have been shown to help reduce chronic kidney disease prevention and optimize blood pressure control. You don't want increased stress on the kidneys either. Protein intake, they need to watch that. So that's something let's not forget about the diet, and protein should be 0.8 grams per kilogram of body weight per day. That's the recommended. And dialysis patients is a little bit different. If you're not pregnant and you have diabetes and high blood pressure, an ACE or ARB is recommended with elevated urinary albumin to creatinine, and strongly recommended if it's greater than 300 and a GFR of less than 60. You always want to watch the creatinine and potassium levels. One other thing to take away from the slide is it used to be it was recommended we put any diabetic on an ACE inhibitor to prevent kidney disease, but that's no longer recommended for primary prevention. So we really should only put them on them if they have microalbuminuria, as discussed on the last slide. And we always want to watch for chronic kidney disease, and we always want to refer, especially if your GFR is less than 30. I usually refer a little bit earlier than that because I'm all about prevention, and I feel like the nephrologists, they went to school and they specialize in that. So if my patient's GFR is around 40 to 50, they have chronic kidney disease from diabetes. So I refer them just to make sure that we maximize the care. It doesn't mean that they have to follow up with them all the time. Sometimes it just takes a couple visits, make sure that they're on the appropriate medication, and then we move on from there. And this is just a recommendation or a table to help you understand what their GFR is, and if they have evidence of kidney damage, diagnose the cause of it, and it could be from diabetes, and then you're going to evaluate. So you're going to start evaluating and treating for complications right around the 30 to 59, which is most likely why they say to refer, but we don't want it to get to that. And then this is replacement therapy, is when your GFR gets below 15 or below 30. That's when you start thinking, is this patient going to need dialysis? And these are just some complications of chronic kidney disease, which you probably have studied at one point. Another small vessel complication is retinopathy in your eyes. So these people have to go every year to have their eyes checked. And again, it's optimizing blood sugars, blood pressure, and lipids, because we don't want any plaque buildup, we don't want any extra sugars, we don't want damage to that small vessel. These people can go blind. Now, adults with a type 1 should have initial dilated and comprehensive eye exam within 5 years, because remember, it's usually complications will come on a little bit different than with type 2. By the time you're diagnosed with type 2, many times you've had diabetes or pre-diabetes for 10 years prior. Then you follow up every 1 to 2 years. This just tells that there are some telemedicine, programs, and women should also, that are pregnant, should have an eye exam, and as well as before pregnancy or in the first trimester, and then monitored every trimester. These are people that already have pre-existing type 1 and type 2. And then we refer to ophthalmology, which we usually do anyways. And so this is the other thing, the presence of retinopathy. It's not a contraindication for aspirin therapy to protect the heart, because it does not increase the risk of retinal hemorrhage. Some people have thought that in the past, but it does not. Now we go to neuropathies. Think of nerve damage. It's a diagnosis of exclusion, so it's really important to get a good history, although people that say that they have burning and tingling in their lower extremities, usually if they have diabetes, you can pretty much pinpoint that it's probably that. But remember, we need to check for peripheral arterial disease. Do they have good pulses? And maybe it's a vascular issue. So you need to be able to decipher between the two. Do they have intermittent claudication that would lean more towards peripheral arterial disease? How are their pulses? What is their leg like? Is it pale? Whereas diabetic neuropathy is usually the opposite, where they have just burning, numbness, tingling going on. So everyone should be diagnosed, especially type 2. And then type 1 is a little bit different because type 1 usually comes on suddenly. It's a different kind of management, and as well as complications have a different timeline to it. You can do, as far as assessing, the pinprick with the monofilament testing, and they can have some autonomic neuropathy too. So there's also gastroparesis. So again, optimal glucose control. These people need to change their lifestyle. And I think a lot of it comes down to the way that they're eating and taking care of themselves outside the doctor's office. As far as treatment, there's Lyrica, which is the pregabalin, duloxetine is Cymbalta, or gabapentin. Gabapentin can make you really tired. Lyrica is like gabapentin with less tired effects to it. It can cause some weight gain, as well as gabapentin. Duloxetine is Cymbalta, so it's a good drug to use for someone with depression and pain issues, but those are all indicated. You always start low and go slow, and then you increase it. I'm not going to go into complete detail about foot care, but once a year they should have a comprehensive foot evaluation. I usually do a quick one every time they come in, but I send them to podiatry, but that will be your preference, and depending on where you work will depend. Because remember, things start in the feet. They're the extremity that's the farthest from the heart. And so you can have athlete's foot and then just get one little piece of bacteria in there. And if you have too much sugar running around in your body, you're not going to heal from that. Also, with the claudication, we may want to get ankle brachial index because that'll help determine the circulation if there's any issues leaning towards peripheral arterial disease. And of course, we always do education for patients, and then these are risk factors. Poor glycemic control, smoking, we know that infiltrates to every part of our body. Peripheral arterial disease, any foot ulcer, amputation, visual issues. So visual impairment, meaning they could not see where they're going, they can stub their toe and end up with an issue if they have a callus or corn. That's why I send a lot of these people to a foot doctor. And that is it on section 10 and 11.